meet me at the dark. Finally, I can see you crystal clear.
Professor Jack Lee. Dr. Lee is the Dean and Professor at the College of Medical Science and Technology at Taiwan Medical University, and has done an enormous range of things within informatics. And I think his talk will complement this last one well. He'll be saying some things about big data and what the value of that will be. Dr. Lee.
Thank you, David, for the introduction. Instead of talking on the whole scale of healthcare system in Taiwan, I would like to talk to you about a small topic, which is how to use the big data approach to improve quality and patient safety. It's not a small topic, but it's a focused topic. This is where I come from, Taipei Medical University. I have to do this, you know. It's a small university with 6,000 students and about 600 faculty members. We're all JCI accredited hospitals. There are 3 teaching hospitals with a total of about 3,000 beds. It's closest to the world's second highest building, Taipei 101. So you've heard a lot of talk on electronic health record, electronic medical record, but why do we spend so much time and money on electronic health record? Do we want to go paperless? We may or may not want to do that. NT says that that's not their goal. Does it make it easier to read so the legibility is better, so there are less mistakes? Do you want to do automatic translation, like from one language to different language for medical tourism? Or we want to translate professional terms to layman's language so that the patient would, easier for the patient to understand what's being recorded for their health conditions. Of course, EHR will provide speedy access and also concurrent access, meaning many people can access the same record at the same time. But again, in the end of the day, I would argue the most important thing that the most important reason why we want to do EHR and invest so much on the electronic health record is because we want to provide data to improve quality and safety, okay? And if we accumulate a lot of data, then why not just call it big data? But actually, there's a definition for big data. One of the definitions says that a big data is a collection of data set, so large and complex that it becomes difficult to process using on-hand database management tools or traditional data processing applications. So it's not just big, it's also complex, right? And also there are several dimensions of big data. Again, the first dimension is complexity. Okay, it's not very straightforward. It's not just a lot. In our healthcare related data like EHR, it's not just a lot, but it's very complicated. The amount of value that can be derived from innovative versus traditional analysis techniques. Meaning if we can just do it business as usual using traditional statistics, traditional analytic tools to do it, then it's not such a challenge. And also the use of longitudinal information to supplement the analysis. In EHR, we frequently encounter the time series analysis as a challenge, but also as a very useful, actually, very significant dimension of the EHR data analysis. And we all know about this. I mean, people who come to this meeting know about the current status of healthcare is there's still much to be desired. But one key is that the information is often not available from this, of course, from the IOM report. The information is often not available to those who need it when they need it. But again, it's easier said than done. How do you deliver information to those who need it when they need it? How do you know who need them? And how do you know when they need it? Okay, so it's not that easy to accomplish that. And we know that the quality of care is again, still not very up to our standard. Actually, 45% of the people do not receive recommended care. In pneumonia especially, 61% people did not receive care based on a paper from the New England Journal of Medicine. So how do we use the data that we have? I mean, many hospitals have invested a lot of resources into their electronic health record. So now it's probably time that we both go back and reflect on the kind of data that we have to, to actually improve quality and patient safety. One model that we proposed in 2004, we call data interaction model, is that we use 5 elements or 5 variables of data, including patient profile, lab and examination data, medication data, procedure data, including surgery, and as well as diagnosis and problem list. These are the data elements that you find commonly in your everyday electronic health record. But when you look at them in this 5 different elements, and you look at their interaction, you find problems. For example, if you look at medication, and you look at, maybe it's too small to read from there, but if you look at 2 medications, for example, ciprofloxacin versus aminophylline, issued to the same patient, then you notice that there might be some drug-drug interaction, okay? That's why many hospitals would actually deploy drug-drug interaction reminder in their CPOE. And that's utilizing only one dimension of the data, which is the medication data, okay? And if you can, of course, utilize each element of the data to detect error, okay, and potentially improve safety. You can also look at 2 elements of data. For example, if you look at medication versus procedure, and you look at one patient with warfarin also scheduled for an angiogram, then you might pop up some reminder and say, okay, the patient will have bleeding tendency and might not be suitable for angiogram unless you discontinue the warfarin for several days. So if we look at one-way interaction, just look at drug, look at medication. We can have drug-drug interaction, as most common example that's been implemented in many hospitals in Taiwan. And also redundant drugs, reminder, meaning if you issue 2 similar drugs to the same patient, then you got reminded. And maximum daily dose for children and adults, unusual frequency. For example, if a drug is usually given once a week, and you give the drug 4 times a day to the patient, then it's considered maybe unusual frequency, and maybe it's a mistake. Inconsistent route, dosage form, very simple mistake would be using a syringe, a vial, for external use. It will be a very uncommon or inconsistent route or dosage form. And also, when you use high-alert medications, you make sure that this is really the medication you want to use. So these are examples for one-way, for what we call one-way interaction. And also, there are many examples of two-way medication, two-way interactions. For example, there are pregnancy restrictions of the drugs. So if we know patient profile, from the patient profile, we know that the patient is pregnant, then there are drugs that should not be used. And there are contraindications, meaning if there's some diagnosis, then some drugs should not be used. And of course, drug allergy detection. If a patient is allergic to penicillin, you should not issue penicillin to the patient. It sounds very straightforward, but it's not. And drug versus lab, of course, if you have liver or kidney function problem, there are some drugs that you have to adjust the dose. We call it therapeutic dosage. Or drug versus procedures. For example, the example that I just used. Blood thinners with the angiogram should not usually happen together at the same time to the same patient. These are some of the examples that we've done over the years. This is one drug-drug interaction reminder and response system. It tells you, of course you cannot read this, but yeah, well, some of you can, but it tells you that the patient is issued Clariset, which contains clarithromycin, and Soin, which contains theophylline, and they have a moderate evidence that they will have drug interaction. And the action is that the toxic of self-feeding will be increased. So there will be palpitation, arrhythmia, blah, blah, blah. And the solution is change your clarithromycin to azithromycin or reduce the dosage of self-feeding by 25%. Okay, that's kind of a typical drug-drug interaction reminder. Actually, we do not have this recommendation until Dr. David Bates visited us back in 2004. I think it's about 2004. So we add this recommendation. And the doctors can respond to it. And also, doctor can check more on each drug information. This is quite the common function now for most of the hospitals around the world or in Taiwan, that you can check the drug information. And this is pregnancy. So when the patient is pregnant, this icon will lit up, and it will tell you what is the FDA grading of pregnancy for each drug that you prescribe in the CPOE system. This is a drug allergy reminder. Of course, when you're allergic to drug A and you issue drug A to the patient, you will be reminded. But again, there are cross-reaction of drug allergy. For example, if a patient is allergic to penicillin, you might want to alert when a physician issue ampicillin as well. Okay, and also same for a lot of NSAID. And we can monitor all the drug-drug interaction every month and the ratio of drug-drug interaction, see if they change. And we can also facilitate departmental learning by feedback each department or each doctor's drug-drug interaction records to themselves. Also, we also link our CPOE to MD Consult and a database like that, so they can have a on-demand learning or just-in-time learning for the doctors. This is an example of drug lab reminder for conscious media versus renal function. So if the patient is ordered, say, for example, a CAT scan with conscious media, and the renal function, BUN, creatinine, the renal function of the patient is not normal, then there will be a reminder popped up and ask the doctor whether you want to do this or not. And there are many different situations. This is just one situation. We implemented the system to the hospital, and it has prevented about 200 cases a year of we call A+ risk, high risk conscious media administration, meaning the renal function is bad, and the doctor did not notice about it, and they issue some conscious media related examination. We were able to stop about 200 cases a year. This is another simple information, a simple system that facilitates on a one-way data interaction, meaning we only use the surgery data. 5 minutes before the surgery, before we start to prepare the patient, the doctor, the surgeon are required to enter which side you want to operate upon. That is the left side, the right side, bilateral, or not applicable. Okay, for some surgery, there's only, so they click on it, and then the system will tell you, okay, this is the same side as your scheduled side, or not, okay? And we found out, after 4,000 surgery, we found out that 15% are inconsistent, meaning they schedule for left, and they click on right, okay, or they schedule for left, right, and they click on bilateral, okay? So there is a lot of inconsistency, okay? But anyway, when we go back and look at the data interaction model, there are 5 one-way interaction, meaning each data elements. If we look at each data elements vigorously, we can find many, many different ways to use the data to improve safety. And if we look at 2 data elements, there are 10 combinations, right? And there are, if we look at three-way, there are 10. So there are 31 combinations. There are a lot of combinations to it. But when we go to examples like drug versus diagnosis, that's a 2-way interaction, right? In our model, it's a 2-way interaction. So we would like to let the system know that when the patient has diabetes and doctor issue euglucone, which is glibenclamide, it's a lowering the sugar. It's an anti-glycemic, hyperglycemic drugs. It's okay. But if the doctor accidentally pick euclidin, which is a vasodilator, then it's not okay. Okay? But this is very difficult to create a rule. You know, there are too many rules like this if you want to create them. There are too many combinations and there are too many exceptions. So there's no way that we can do this on a rule-based manner. That's why we kind of enhance this to a probabilistic data model. So we take any number of the data elements from the data interaction model, and we compute their association strengths. We use Q as the association strength. This is not a very complicated formula. It's actually a ratio between these two events happening together naturally, and these two events happen randomly together. Okay, so when Q is 1 means that they are independent events. One events do not incur or increase the probability of the other events. Okay, so when Q is larger than 1, they're associated. When it's less than 1, they're negatively associated. So we should use all the combinatory Q among the data elements to determine the probability of the occurrence of a specific combination. For example, if we want to do a drug diagnosis interaction, first we have to look at all the prescriptions we have. So we went through about 103 million prescriptions, okay, which is only 3 years of prescriptions. So 100 million prescriptions, it's got about 200 million diagnoses in ICD and ICM code, and about 347 million drugs in ATC code, which is a WHO standard code. From Taiwan's National Health Insurance Database, we do have a health insurance database for almost all the prescriptions in Taiwan for 15 years. Actually, it's been 17 years now. And each year, the whole country generates about 360 million prescriptions. We do give them a lot of drugs. And it's kind of free. So, and we compute all the association strengths between the diagnosis and drug, and also drug and drug. Okay, and I think and then we determine the appropriateness of prescription by the Qs. I think this formula is very self-explanatory, okay? So you will totally understand what I'm saying, okay? After that formula, then we'll be able to remind our physicians something like this, okay? A drug diagnosis reminder under the diagnosis of XYZ. It is uncommon to prescribe the following drug, drug 1, drug 2. Do you want to modify them? Okay, so this kind of reminder cannot be achieved by a rule-based. It's very hard to achieve by a rule-based manner. You will have many, many exception rules and many, many rules. Okay, and that really depends on the age, the gender of the patient, the disease of the patient, and all kinds of factors. So we've tested our probabilistic data model for about 1,400 prescriptions, and they're evaluated humanly by physicians and pharmacists. And we found that the reminder is about 96% accuracy for appropriate prescriptions and about 45% accuracy for inappropriate prescriptions, with a sensitivity and specificity of about 75 and 89. We're still trying to improve it, but you get the idea that it's actually possible when we have big enough data to look at the interdependency or the associations of each data elements, and from that we'll be able to find unusual combinations, and these unusual combinations may be errors that can be prevented. We also exercise monitoring. Well, actually, let me see. Yeah. Okay. We also exercise monitoring of patients with their risk. This is in the ICU. These are a list of ICU patients. When the risk of the ICU patient increase, then you get this reminder. And when you click on it, it tells you what are the items that the computer thinks is at risk. So with the big data approach, I think quality and patient safety can be improved several orders of magnitude significantly. One hospital, in one of our hospitals, we were able to capture about 20,000 high-risk events every year. It sounds like a lot, but again, if these are not high-risk patients, they will not be in the hospital, right? But we need to know who are at what kind of risk. So we're moving gradually from intervention after something happened to prevent something happen to predict. Actually, if you cannot predict, you cannot prevent, of course. This is the airport tower, a very artistic shape tower of the Edinburgh Airport. That reminds me of something that we should have in a hospital, because in the airport, the only thing that's high-rise is the tower, right? And why are they high-rise? And why do they have a transparent 360-degree looking window? Not because the view is better. It's because they want to they want to monitor all the high-risk events, which are taking off and landing. So I think our hospital also should be equipped with a patient safety tower that tells you where and when and what kind of risk that your patient are going through. Then eventually we might be able to achieve a better quality and patient safety through the information technology. Thank you. Oh, by the way, one message. We have a booth at the first floor from the Taiwan Joint Commission on Hospital Accreditation. They have been showcase on smart hospitals in Taiwan. So if you're interested, you're welcome to visit our booth. Thank you.
Thank you. So we have some time now for questions. Can I ask NT to come up also? And could we have the lights up just a little bit so we can see out? And John, first question.